a great pleasure to chair the first plenary of this meeting and to welcome Joanna Wardlaw, who's going to give the lecture. Joanna, of course, is well known to many of us and a key player in the VCI space. She has a chair of applied imaging and she's head of neuroimaging sciences at Edinburgh, where she leads brain imaging studies into VCI, but also into ischemic stroke, where she's also done a lot of very excellent work. She's really best known, I think, for her work on imaging small vessel disease, and she's led several international initiatives in this area. Maybe one that we're most familiar with, the STRIVE standards for reporting on small vessel disease on imaging, which reported about 8 years ago, and I know the paper's been cited over 2,500 times, which is absolutely fantastic. She set up imaging networks in Scotland, the Synapse network, which is a very highly regarded imaging network in the UK. She's also part of the recently formed UK Dementia Research Institute and leads also clinical studies. Although she's a neuroradiologist by background, she's leading clinical studies, including one called R4VAD, which is a prospective study in the UK of post-stroke dementia, which I'm sure she might mention. So Joanna, it's absolutely wonderful to have you here to give the first plenary, and over to you.
Thank you very much for the invitation. Next slide, please. These are my disclosures. I have no industry or commercial disclosures. Next slide, please. So I've been asked to talk about clinical vascular cognitive impairment. Originally, when people first started thinking about dementia, they assigned many of the causes to vascular disease. And then in the early last century, it became more interesting to examine Alzheimer's disease. And then more recently, the interest in vascular disease has flipped back. And this is from a review several years ago by our chair, John O'Brien, highlighting several different potential mechanisms that might underlie vascular cognitive impairment, including multi-infarct, small vessel, strategic infarcts, low perfusion, hemorrhagic cerebral amyloid angiopathy, and of course rare hereditary vasculopathies, and probably the most common being mixed Alzheimer's and vascular pathologies. And I must admit, I think as we go forward, increasingly that things are mixed, that symptoms don't always fall nicely into a sort of stuttering pattern, which you might expect to see from vascular causes, that even the idea that vascular is primarily something that you see with abnormalities in executive dysfunction rather than memory is perhaps not quite as clean cut as one might think. So I'd like to highlight a few things in this talk from recent work by our group, but also others, which hopefully will advance things and highlight some of the symptoms, which in fact are probably more prevalent than we realize. Next slide, please. Next slide. Could you advance the slide?
We're trying, Joanna, but I think...
Sorry.
I don't know, it's something's... Yeah. No?
Aha. And next slide. Stroke, of course, is a major cause of vascular cognitive impairment and dementia, and this graph is well known from the work of Sarah Pendlebury and colleagues in Oxford, which was updated a couple of years ago, showing time after stroke and increasing diagnosis of cognitive impairment and dementia, and a number of risk factors associated with it, including recurrent stroke rather than first stroke, severe stroke, low education, increasing age, prior cognitive decline, etc. And a further recent update, just to draw your attention to now in press, from Louise Craig and Terry Quinn and colleagues looking at dementia at 1 year, finding very, very similar patterns. About 18% have dementia 1 year after stroke, whether you include or exclude pre-stroke dementia, about 20% if you include pre-stroke dementia overall. Next slide, please. And of course, what is also reasonably well known, but perhaps less well appreciated, is that cognitive decline is quite a common observation preceding stroke, so leading up to the stroke. This is from work in Sweden some years ago, but there's several other studies that have found similar things. These are otherwise healthy individuals who have not had a stroke, whose cognitive performance was tracked. And in the time leading up to the stroke, those in whom the cognitive function declined most precipitously, or most were more likely to have a stroke than those whose cognitive ability remained fairly stable. Next slide, please. So that's cognition in the years just leading up to the stroke, but I would also like to draw your attention to the increasing evidence, now really very established, about how early life factors, including cognitive ability in early life, predict both stroke and small vessel disease and cognitive impairment. So this slide summarizes data from several meta-analyses. Can you, next slide, please? And again, next slide, please. And again, and whether you look at populations and you look at an outcome of stroke, or you look at small vessel disease burden in the yellow, or something we've just replicated in 4 community cohorts in blue, you find that having a lower versus a higher cognitive ability in childhood or young adulthood is associated with an increased risk of stroke, with an increased risk of having more white matter disease or a total small vessel disease burden. Similarly, having less educational exposure has a higher risk of stroke, has a higher risk of having worse small vessel disease in older life. And in the 4 novel cohorts, which that's now in press in Brain, what we've been able to do is differentiate between the childhood effects and the effects of subsequent exposures in adulthood. So these effects in childhood are independent of adult vascular risk factors and adult socioeconomics. And we're still seeing this trend for early life cognitive ability and educational exposure to be risk factors for having worse vascular disease in later life. And of course, that translates to a higher risk of vascular cognitive impairment and dementia. And when you look specifically in patients with stroke, in the green box at the bottom, you find that one of the strongest predictors of cognitive impairment and dementia in the year following stroke is having worse premorbid cognitive ability. So this is an estimate of peak early adult cognitive ability. That, along with age and white matter hyperintensity severity, were the strongest predictors of cognitive impairment post-stroke. So I think what we need to do is take much more account of prior abilities and educational exposure than we do at the moment. Next slide, please. And I think the other thing that's increasingly apparent, particularly in intensive studies, is that whether somebody notices if they've had a small vascular event in their brain or not, it seems to be somewhat arbitrary. So along the top row, you see a series of slides illustrating diffusion images showing recent small subcortical or cortical strokes, all of which were noted by the patient and they went to hospital. But it's also fair to say that some patients who have a stroke don't have any lesion visible on their scan, no matter how sensitive the scan. And equally, some people can have stroke lesions visible on their scan, but they've had no symptoms. So in the bottom 2 rows, there are a series of examples of white matter lesions and also stroke lesions, which were not associated specifically with any focal neurological symptoms. And increasingly, white matter diseases looked on as being not necessarily silent or asymptomatic, but actually covert. Silent infarcts, so-called, are present in about 20%, and white matter hyperintensities in about 90% of community dwelling people between the ages of 60 and 90, and they haven't all had stroke-like neurological symptoms. Next slide, please. And of course, white matter hyperintensities themselves are associated both with an increased risk of dementia, stroke, and death in people who have not yet had a stroke. And next slide, please. Also increase the risk of post-stroke dementia, recurrent stroke, etc. So these are important lesions, and the idea that they are somehow completely asymptomatic seems really strange. So if you could, next slide, please. We've been looking in some studies at whether or not these lesions are indeed truly silent, or whether they might carry some perhaps not so well recognized symptoms. So this is work from Una Clancy, who's Chief Scientist Office funded research, clinical research fellow. And she's recently published a large meta-analysis in Lancet Psychiatry looking at a range of neuropsychiatric symptoms and subjective memory complaints, and whether or not these are in fact associated with white matter disease in the brain. And this builds on a number of previous studies which reported apparent associations, although these were not sort of active pursuit studies. Next slide, please. So what Una has found in quite a large number of papers that were able to contribute to this meta-analysis, next slide, please, were that worse white matter hyperintensities were associated with apathy and delirium and fatigue, but they were not consistently associated with subjective memory complaints. And most of this was cross-sectional. There was very few longitudinal studies to determine whether these symptoms were in fact predictive of longitudinal change. Next slide, please. Again, sorry, next slide, please. Thank you. Next slide, please. Thanks. And then the other point is, sorry, back one. Yeah, thanks. There's been a huge focus on the executive dysfunction component of small vessel disease and vascular cognitive impairment. And recently we asked the question as to whether, in fact, if you looked closely in cognitive domains of memory and visuospatial ability and so on, so 7 major cognitive domains, were these domains also in fact affected in patients who had small vessel disease? And this is a large systematic review undertaken by Olivia Hamilton. And what she found was that when you look in case control studies, we have small vessel disease versus control population, and she also looked in small vessel disease divided according to whether the patients had presented to a stroke clinic or to a memory clinic. She found consistently across these populations that all of these cognitive domains were actually affected. So it wasn't just processing speed or executive function, but also memory, attention, visuospatial ability, reasoning, and language were all similarly affected. Next slide, please. And interestingly, if you looked and you compared the cognitive versus the stroke populations, the cognitive populations performed slightly worse on memory tests. But apart from that, there was no other difference. They were similarly affected in terms of executive dysfunction and the other domains which I've just mentioned. And one of the interesting things was that if you looked at years of education between the small vessel disease and control groups, then years of education accounted for some of the difference in cognitive test scores in the domains of memory, executive function, and visuospatial ability, but not processing speed. So as if processing speed is, if you like, sort of hardwired, whereas memory, executive function, and visuospatial ability are potentially modifiable through having more exposure to education. Next slide, please. So recently, I'd just like to highlight a study that we've been doing where we've been looking longitudinally at patients presenting to our stroke services to see whether they do indeed have symptoms related to progressing lesions, which might help identify people who have worsening or bad vascular disease and worsening vascular disease, rather than waiting for them to have a stroke or develop overt dementia. And again, this is the work of Una Clancy. Next slide, please. So essentially, we examine patients clinically. They are admitted to the study after a small stroke. Next slide, please. And then we follow them serially with cognitive assessments, MRI assessments, a number of lifestyle assessments, physical function, and so on. Sorry, next slide, please. And what we found is an alarming number of individuals have not only their original index lesion, but they also have recurrent lesions. And this is an example of a relatively typical patient who, in addition to their original lesion in the right internal capsule, developed a number of unexpected lesions in other parts of the subcortical tissues, just because, which we would not have known about had they not been participating in this study and entered the scanner. Next slide, please. So when we've looked at these in relation to neuropsychiatric symptoms, it seems that people who have recurrent lesions visible on diffusion imaging have higher apathy, fatigue, unsteadiness, falls, and IQ code scores, but they don't have anxiety or subjective memory complaints that are significant, dizziness or headaches that tend to point to these same symptoms being markers of worsening white matter disease. Next slide, please. The other thing that we've been able to look at, next slide, please, is change in white matter hyperintensities as another major marker of vascular disease. And this is from several different studies. We originally saw that some white matter hyperintensities decrease as well as increase, and that was also noted in the RUN-DMC study. And Una has also been able to look at the Sunnybrook dementia study, and we've also looked at subjects in our Lothian birth cohort. So 3 completely different sets. And what we found in each of them is that there's this pattern of some white matter hyperintensities that decrease and some that increase, depending on how long a period of time you examine, and that these increases and decreases seem to be related to symptoms. So next slide, please. This is data from our ongoing study where I just showed you the example of the recurrent acute diffusion, little tiny subcortical lesions. And we're seeing, this is ongoing, so this is incomplete data, but what we seem to be seeing again is this pattern of some people have decreasing white matter hyperintensities, some people have increasing white matter hyperintensities. And the risk factor for those are for increasing or having a high small vessel disease burden, worse current socioeconomic status, worse pre-morbid cognitive ability, and a couple of lifestyle and vascular risk factor related things. But when you look at the white matter hyperintensities in relation to change in cognitive ability, just using the MOCA, or change in physical function on the right-hand side, looking at the timed up and go, very interestingly, what you seem to see is a general pattern emerging, which suggests that in the people whose white matter hyperintensities are shrinking, they're getting faster on the timed up and go. And those whose white matter hyperintensities are worsening are getting slower on the timed up and go. And similarly, a sort of pattern of perhaps improving on the MOCA and decreasing on the MOCA. But as I say, these are ongoing. Next slide, please. Some similarities were seen in the longitudinal RUN-DMC follow-up study, where they've looked at white matter hyperintensity change and cognition, and those in whom the white matter hyperintensities tended to decrease maintained their cognitive ability, whereas those in whom the white matter hyperintensities worsened had worsening cognitive ability, and they didn't find any relation between white matter hyperintensity change and gait per se, but they did find associations between white matter atrophy and reduction in stride length. So again, a physical manifestation. Next slide, please. What we've also been able to look at is fluctuations in white matter hyperintensities in the Sunnybrook dementia study and neuropsychiatric symptom fluctuations. Again, finding some associations between having a higher prevalence of neuropsychiatric symptoms and worsening white matter hyperintensities. So neuropsychiatric symptoms seem to be an important marker of fluctuating vascular lesions in the brain. Next slide, please. A couple of things just to highlight at the end. So this is work of the Meta-VCI MAP consortium led by Geert-Jan Biesels from Utrecht and colleagues. And they've been very interested in the question of whether there are relationships between the location in the brain of specific vascular lesions and your risk of post-stroke cognitive impairment. And indeed, in the recent Lancet Neurology paper, first author Nick Weaver they did find an association between specific areas in the brain being affected and having a high likelihood of having post-stroke cognitive impairment. And those regions included the left frontotemporal lobe, right parietal lobe, and left thalamus. And if any of those areas were affected, regardless of the size of the actual infarct, then about 80% of those patients had post-stroke cognitive impairment. And there were other areas that were associated with low risk. However, what this hasn't looked at yet, and next slide please, is the relationship between the index lesion, if you like, and what else is going on in the brain at that time. So this slide is from a small study, which needs obviously to be replicated in larger studies, and that should be possible in things like the meta-VCI map, where we looked at specifically at patients with lacunar ischemic stroke, and we looked at the lacunar lesion locations as an acute lacunar lesion, small subcortical infarct, and the relationship to background white matter hyperintensities and other established small vessel disease features. And what we found that so we only looked at places where these small subcortical infarcts are common, such as the internal capsule or the centrum semiovale, and neither of those two areas in their own were particularly associated with cognitive impairments after the stroke. However, when you factored in the location of the white matter hyperintensities, then you found that there were specific areas where if there was intensive effect by white matter hyperintensities, then the presence of that small subcortical infarct modified the relationship between the white matter hyperintensities and cognitive impairment. So I think it's important to go on and look more intensively at not just the index lesion, but also at the more diffuse effects that are happening in the brain. Next slide, please. Nearly done. So just to sum up, what I'd like to try and emphasize is that when we see somebody in their 50s or 60s or 70s or whatever, that's what they're like right now, but it's not always what they were like. And we're just getting a snapshot, and that snapshot may not really get over to us the dynamism of what might be going on in their brain. And also what you see in that person is everything that's happened to them up until that point in their life. So where they are on the cognitive trajectory will be influenced by their cognitive ability in youth, which in turn is affected by things like, genetics, a number of adversities to which they may have been exposed from youth onwards, to adult risk factor and lifestyle exposures, to then whether or not they might have a stroke and what happens after that, all of which is kind of reflecting a balance of resilience or vulnerability to brain injury. They may be someone who has a lesion that shows up on their scan, or they may not. And these are quite different. So I think it's really important that we start to take as holistic a view of this as possible. And bear in mind that many of the symptoms that these people are having are not traditional neurological stroke symptoms, but neuropsychiatric. I think we really need to be more broad-minded about funny neurological symptoms. They might actually mean something. So next slide, please. Yes, and cognition, as you know, is a major concern of patients with stroke. There are several studies highlighting that cognition it's not just a concern to people who are affected by dementia, who've had experience of it, it's also of considerable concern to people affected by stroke, from a number of sources, including just looking at a number of unsolicited inquiries which we've received. And also, next slide, please, the recent very comprehensive work by the Stroke Association with the James Lind Alliance, to which I would strongly encourage you to read. So thank you very much, and I'm happy to take questions.
Great, thanks, Joanna. That was a great overview of the area. And we've got a couple of minutes, despite the technical problems. We've still got some time for questions. So maybe I could kick off. I mean, you touched on it at the end, but this finding of low IQ and low education being associated with lesions, despite what happens to you sort of after that, in a way, is quite interesting. What do you think is maybe the explanation for that?
Okay, I think people who are predisposed to developing vascular brain lesions, actually there are processes going on which I don't have time to go into, which influence early in life, endothelial function, which influences early in life things like myelination. There are a number of studies indicating that young adults who are genetically predisposed to develop white matter disease have measurable differences in their white matter integrity in their 20s, long before they've got white matter disease. And what may be happening is that the propensity to be someone whose brain is a bit vulnerable to vascular lesions actually starts really early on. So your sort of settings mean that if you then get something which injures your brain, you are less likely to be able to recover from it. You are more likely to show a lesion. It's more likely to be difficult for you to repair, your myelin, etc. I mean, this is very simplistic, but we have information linking white matter integrity with cognitive ability, particularly processing speed.
So there's a very closely related question in the chat, actually, from Fatima Jeremiah, which is about a role. Is there a role for myelin imaging, particularly maybe?
Yeah. I mean, what's really frustrating, I think, is that we all sit in our little silos a little bit. So if this was an MS conference, we'd be all going on about myelin imaging, but it's not. So we use other tools, and then, we don't necessarily do quite such intent. I mean, there are diffusion methods which give you information about myelin. One of the other problems is some of these techniques are very suitable to people who are happy to lie for hours in the scanner, but not for someone who's a bit challenged, slightly, agitated. They're not going to last in there. So, yes, I think so. Equally, we should be looking at, the venules, not just the arterioles. I mean, there's a whole bunch of questions like that. You can't do everything. And I really encourage people to try and expand out.
Okay, thanks. Paminda, your hand was up, but it's gone down. Is that?
Yeah, no, I wasn't sure if we still had some time. Firstly, congratulations, Joanna. That's a wonderful talk. I just wanted to ask you about regression of white matter lesions. We know that the extent of white matter hyperintensity is actually the best predictor of progression, and they actually increase in proportion to where you start off with. So what actually determines regression, you think? Do we have a handle, obviously, on the pathophysiology or pathomechanisms of regression, and secondly, about protective factors for regression?
So I think what is probably, but this is hypothesis and work in progress, is that, I mean, when you look at MRI or in fact CT, changes in the white matter attenuation or signal intensity change is basically a reflection of the water content. So if you get a hyperintensity, if you look really closely at them when they're beginning to form, they often look a bit puffy. And we have some measurements from other types of modality which suggest that they represent areas of increased interstitial fluid. Now, interstitial fluid could resolve, or if it sits around for a while, it will lead to further damage, and then you'll end up with a more permanent lesion. I suspect, therefore, that some of what we're seeing with regression is perhaps earlier lesions which are able to regress. Again, it's kind of dynamic process. Possibly also, there may be an element where, if you watch white matter hyperintensities, eventually they will start to cavitate, or if they're adjacent to the ventricle, the ventricles start to get a bit bigger. I don't think what we're seeing is simply the ventricular enlargement, because, we've done quite a lot of work to try and make sure that's not the case. But, there's a number of reasons why you might see an overall volume disappearing over time. As the damage gets worse, then you might end up with just a smaller area of scarring. That's not genuine regression, that's just long-term scarring. But if you're simply measuring volume, it might look like that. I think most of what we're seeing, however, in these populations that we've been able to look at are the fluctuations when these lesions are beginning to form, and they haven't yet become permanently damaged tissue. And you can actually see the whiteness looks different. When the ones that do change, the ones that don't change, they're actually quite different when you look closely at them, just even on a flare.
Great, thanks, John. I think that's a fascinating area, regressive lesions. So apologies for the technical problems at the start, but I think in the interest of time, we better move on. Thanks for that wonderful overview. You really emphasised not only the multifactorial nature and impact of small vessel disease, but also the kind of lifetime course, which I think is really, really important. So that's the end of this plenary. I'd like now to hand over to the chairs of the next symposium, Cameron and Daniel.